I come back now. The voice is clear. Yes. Everything is fine. I can share with you now. Yes, okay. I don't know what happened, but I don't know. It's okay. I just share the share. Okay, from where? Yes. Here we. Okay, let's see the chat. Okay, so we should mute all first. Yeah. Okay, all are muted. So let's continue our review in neuroradiology, and we try to fix some issues in the exam. What is the most important to check? And okay, so let's have a look in this case. This is one of the most important cases that you can check in the exam. Differential diagnosis again, yeah. One of the good things that you think about this, that could be Schwannoma, and yeah, that's very nice. And you think about neurofibromatosis type 2, that's important. When you find this Schwannoma, and here, like Myeloma with dural tail, exactly. We mentioned it last time that MSME, multiple inherited Schwannomas, meningiomas, ependymomas. You think about Schwannoma, okay. Let's have a look in this. Is يعني maybe in short question in exam. Yeah. Okay, دكتورة نعيمة. Okay, دكتورة نعيمة. Okay, so it can be Schwannoma, but to be honest, without sequence for contrast, you should. I make mute for Dr. Naima, but I don't know what it come back again. When you make this image, you should look for the contrast, because to see if it is enhancing or not. This is the post contrast image. So okay. So when you have this post contrast image, you should. Yeah, but fat contains, to be honest, this is fat suppression. So when you see this fat suppression, it cannot be fat. It can be contrast, or either something like hemorrhage, but it cannot be contrast. So take care, which sequence are you? If you are in this sequence with fat suppression, so already it cannot be fat, okay? So one of the differential, it can be included Schwannoma, sure, or cyst, or meningioma, it depends, it's take, yeah, Dr. Nermin, yeah, lateral meningoceal, it can be, but without enhancement. But this one, it have intense enhancement. So in this case, you Schwannoma, one of the important things. We have this case, just we have it, okay? And I think everyone now how it looks. I think the Radiopedia cases give you more real practice, and really it's very nice list. I will try to make with you as much as we can this real cases. Acquired Cholesteatoma, we mentioned one of the most common sites for Cholesteatoma, the pars flaccida, Bro-Sachs space, and the differential otitis media, and the diffusion restriction, one of the most important keys. Okay. This case, I think, yeah. When you have this image and CT with CT, and you find something intraventricular. So when you find this intraventricular, and it most involving or ventricles, and also in the parenchyma. So it can be, yeah, hypertensive hemorrhage. Yes, yes. So with no trauma, you think about hypertensive hemorrhagic lesions, and very critical in the exam. You should catch it, and you should post the hemorrhage as a first possibility.
For me to rupture small aneurysm.
Yeah, but the small aneurysm, as you mentioned, it is small. So I think, Also, the small aneurysm, you know, as you know, one of the most important question in exam, the commonest site for each aneurysm. For example, if you have in the area of circle of Willis, like here, so you think about subarachnoid hemorrhage and acom aneurysm. And if you go down to the prepontine region, so you think about basilar aneurysm. So it is very important to check this table. As you know, this very in the text books, you will find that this table is very common in the exam. They mention for you the place, and you mention which common aneurysm should situated here. I think we have this in this review. So yeah, it's more going with something more large. It can be hemorrhagic tumor, it can be BAVM. Yeah, I agree. That's why the MRI with contrast is critical in this case. Spine again, and you find this appearance, especially this appearance with the stair and the high signal in the stair. So what it could be? Put your differential, please. Yeah, but take care, because in the stair image, it is very high signal in the stair. So when it is high signal in the stair, and yeah, you go more with the spine midst. Yeah, so when you high, okay, in the T2, maybe it can be hemangioma, but with low T1 signal and with the stair high signal, and especially if this patient have history of non-primary, so don't rush for hemangioma, because hemangioma is, yeah. So this is very good. I think anyone can, يعني, maybe some people saw it before, but very nice, يعني, explanation. When you find multiple lesion, what you think about metastasis, myeloma, lymphoma, hemangioma, okay, and eosinophilic granuloma, which is Langerhans. When you find that multiple vertebral levels, and when you find يعني common distribution of the tumor location in the vertebra anteriorly or posteriorly. Anteriorly is going more with yeah, malignant tumors like metastasis, myeloma, plasmacytoma, lymphoma, chordoma. You have exceptions, very helpful, which like hemangioma, eosinophilic giant cell tumor, which common extension neural arch. Very nice table and text. Please check it. Yeah. This is like a spot, and it's good if he mentioned for you in the MCQ about the type of patient, which type of patient you have, about the age and sex, and also the clinical, يعني, what his complaint, and what is the treatment. If he mention any of this four, then you get the, yeah, you get it easier. So yeah, this is the pathology here. Yeah, here, yes, here. So what it could be? Yeah. I am fixed to not shift to the next slide, because to, yeah, so what is the differential of osteoblastoma? Yeah, if you mention osteoblastoma, what is could be differential? I am fixed to show you this because, يعني, yeah, osteoid osteoma, yeah. Not everyone know what is but it's yeah, that could be And when you find this osteoid osteoma, don't forget it, because he will ask you what could be next step and what to do. And there is a treatment now, they make it with radiofrequency ablation. So maybe some discussion about this. Okay. So this is the differential of this, and also the isotope scanning. It can be hot. It will be hot in the isotope. Yes. So did the differential of this lesion? It is the osteoblastoma. Yeah. Okay. And I think this is one of the, like, يعني, bubbly appearance, bubbly, and many people like it. Yeah. ABC, or aneurysmal bone cyst, one of the lovely images. Most of us like it because يعني, when you see it. But don't forget that is not just it. يعني you should put differential diagnosis, and يعني don't rush also to be aneurysmal bone cyst, but because there is some differential it can look like, especially metastasis, osteosarcoma, and any sarcoma. So don't rush. Okay. The quality of image is not very, but let's check what it could be. Yeah, I agree. Secondary. Okay, so what it could be, this picture, CT brain with this lesion, and here there is another lesion here, so we have like 2 lesions at least. Multiple meningiomas, yes, could be. What it could be, differential. I think you will change your mind now, right? Yeah, it can be cavernoma with this MRI. Before, يعني you can put any differential, but when you see this popcorn, if you like popcorn, with this hemosiderin appearance around this popcorn, so think about cavernoma. They like it in the exam, and they will ask you what is the most sensitive sequence. The most sensitive sequence, they like it, SWI, as in the chat, SWI, yes. So the SWI is very, very important in such case, because you want to know if there is any, how many he have. Yeah, the T2 star, SWI, gradient, whatever. So this sequence is very important to saw it, and also to know the extent of hemorrhage and if there is any many. Okay, cavernous malformations, at the new term, cavernous malformation with this hemosiderin give you this popcorn appearance. Don't forget it. Sometimes it can come to you in the CT with this hemorrhage, and here if you look just in CT and neglect the MRI, you can give many differential, but with the MRI is very different. You can see this يعني hemosiderin rim and so on, and it can be easy. Okay. Another type in CT, when you saw it, something like this, first question for you, is it intraaxial or extraaxial? So don't forget your approach. Your approach should be fixed. Is it intraaxial or extraaxial? If it is intraaxial, so you have differential, good differential with this pre-contrast and post-contrast with enhancement. So let's go to the other images and see for this similar images for this lesion. Yeah, so why did you mention that is melanoma myths? When you find something in the T2 and is very low, okay, and it takes tense enhancement, so go for differential. One of the good differential that you put, it can be, yeah, melanoma, but melanoma in the T1 it should be high. Here is low. So lymphoma, metastasis and lymphoma it will be, but lymphoma because of the restriction of diffusion. So this is the diffusion weighted image, and this is the ADC. So diffusion weighted images, when you saw something high signal, يعني bright signal in DWI, diffusion weighted images, you cannot say that it is restricted. You just say that it is high in DWI. And this is the most important to look at in the ADC. In ADC, when you find something dark and it was high in the diffusion, then now you have the right to say that this patient have restricted diffusion. Before, you cannot say this. Why? Because you have one phenomenon, which is called T2 shine through. T2 shine through means that still there is T2 effect that you cannot eliminate. So how to eliminate it? You make this ADC. When you make ADC, which is like equation that help you to prove that this patient have true restriction. Let's talk about it more and more in the next cases. So this patient have true restriction, and when you have true restriction, you think about either lymphoma or high-grade glioma or something metastasis which can make restriction. But in this case, with يعني low T2 signal is going more with lymphoma, especially if this patient immunocompromised or he have history of this immunocompression. They like it in the exam, yeah, they like it in much. So you will find it, inshallah. يعني, I hope that you not find it, but you'll find it, yes. So let's check midline lesion, which have like a crossing appearance. Again, yeah, again, put lymphoma in your consideration. Lymphoma, metastasis, put it in all your consideration while you are moving everywhere, okay? Thank you, Dr. Muhammad. Yes. So what about this image? Let's shift more and more. Yeah, I feel that you want to say that there is something. This is the clivus. Yeah. So the clivus have something here and have this lesion, right? So what is could be differential? Yeah, I feel that you won't say like chordoma, exactly. So don't forget that when you find midline lesion, put chordoma, but not just chordoma, you put differential diagnosis, because it is like a tricky case. They put for you like to hunt you. So don't rush in hunting, just say that can be differential, chordoma, metastasis, chondrosarcoma, especially if they have calcification. But at least that you think about that is bony lesion. It is come in the bone. So when you think about it, you can reach diagnosis. So chordoma in the clivus, I agree with you. Just think about the differential, giant cell tumor, metastasis, myeloma, lymphoma, plasmacytoma, Ewing sarcoma. Yeah, chondrosarcoma, yeah, exactly, I agree. So chondrosarcoma involving Ewing sarcoma, any type of okay, clivus. It's like the clivus and like also the sacrum. So it can come to you in the sacrum when we go in the other systems, inshallah, in the future. Okay, so what it can be, you see this image with multi-level and soft tissue component, and the post-contrast image. This patient already have operation and they have soft tissue component. And when you see this case, both differential, both anything, but don't forget the management. This patient is very critical to call and to mention to the neurosurgeon that this patient have cord compression. He have something very critical. You should talk about it, okay? So the most important to go for the management and to inform the clinician. It can come to you like this. This is good differential for the enhancing component. Yeah, it can be infection, I agree. It can be what else? Tumor, yeah, like lymphoma. It can be metastasis, yeah. Yes, yeah, okay, hematoma, but hematoma enhancement in hematoma is very weak. So this is again chordoma. It is a bit, yani not common, but it can happen, okay? So put all differential, but don't forget cord compression, please, because this is critical for the patient. And if you don't mention it, even in the management, it will be yani less marks for you. Okay. One of the good differential, and you can put, yes, giant cell tumor, because it reached to the subarticular level. Yeah. When you find it go to the articular level, so don't forget to mention giant cell tumor, and it go away from the midline. So differential again, differential, but yani put it in consideration. Okay. This patient have this appearance. Yeah, is putting, and most of us like this lovely appearance with this line, and this line yani come like you the image like this to say to you DVA, developmental venous anomaly. When you find like this line come to you in the image, and he say to you like, please, this is a DVA, okay? So yeah, venous angioma or DVA. It is different from cavernous angioma. Cavernous angioma, we mentioned it before. It has this popcorn appearance with hemosiderin chocolate, okay? So it's very different, okay? So yeah, don't touch lesion. I like this. When you see this, don't touch lesion. Yeah, this, don't touch lesions. Yeah. Another example, when you saw it, I think most of us saw this appearance. This is the allergic non-invasive allergic fungal sinusitis. When you have just hyperdensities without bone involvement. When you find bone or widening or bone affection, so it go more with the invasion. Okay, so what is the differential? It can be secretion, it can be hemorrhage, it can be calcification. I think this is easy. Everyone saw it before. Let's go to this differential. Yeah. So yeah, when you find the skull of young patient, young patient, you remember when we talk about eosinophilic granuloma or Langerhans, when you find the skull of small or young patient, don't forget to put the Lytic scale. One of them is very important, eosinophilic granuloma. Also, Mets lymphoma can make this Lytic skull, lymphoma even, epidermoid, dermoid, leptomeningeal cyst, post-operative Paget, hemangioma. Paget, but it will be someone who is old. So when you see this young patient, don't put Paget. But when you see it old patient, put Paget and try to neglect eosinophilic granuloma. So depend on what you see and the age. And they like it in MCQ. They like this differential to make clinical, and the clinical will guide you which one it can be. Okay. Yes. So multiple lytic lesions. Again, put one of them multiple myeloma, especially if this patient is old age. Okay, and they have osteopenia, some osteopenia in background of osteopenia. So don't forget to put this. Yes. Mets also very nice. We mentioned it. Yeah. But if it is multiple epidermoid, I think it will not be. But if single, both epidermoid cyst. Yeah. Again, X-ray spine. One of the very important that you can have checklist. What is the checklist? That you have items that you go one by one to exclude any abnormality. For example, you check the alignment, and the alignment include all the line of the spine. So you go further line by line to check if there is any misalignment, and you go to measure or to check at least the measurement of the perivertebral and some measurement here between the optician and the anterior part of foramen. Exactly. So Dr. Shireen, she go to atlantoaxial subluxation. So what could be atlantoaxial subluxation? And or maybe you can call it here I think it go with basilar invagination. Yeah. So this is one of the most important question in the exam. What is the causes of basilar invagination? So the X-ray is a bit subtle, but here I think now retrospective, if you concentrate in the dense or odontoid, you will find that it is up. So go back more further, and it's very important differential diagnosis in every exam. I think you will have it. Basilar invagination. If this patient is old, go for Paget. If this patient is young, go for fibrous dysplasia. More younger, rickets, osteomalacia, osteogenesis imperfecta, and arachnoid cyst, cleidocranial dysplasia, hyperparathyroidism. Don't forget it, it's very important. Try to make this BF, Roach, whatever, any word that remember you with Paget, fibrous dysplasia, rickets, whatever. Okay. Here, this some measurement that can help you to be sure that if there is any misalignment between the atlas and the axis and the atlas, if there is any misalignment, these lines you should be carefully look at least to McGregor sign, McGregor line, and this I think it's very, very important in the exam, and it's very subtle. So when you check the X-ray, you should by your eye you should check if this lines, if you check it, you will find that the odontoid is upward displaced. That means that there is misalignment. I think you will find very good article in radiographics, and the one very good article also in ACR I will share with you in the group. It have all this measurement, and it have many very good examples for the atlantoaxial dislocation that will help you to read this very good. Just this, the most important interval, atlantodental interval in adult should be less than 3 millimeter, in adult 5, in children 5 millimeters, and so on. And all these lines you should be aware about them. Okay, I think this one we mentioned it before. I think it's easy one now, not very easy, but easy that you can look in this parasagittal, or in the course of the superior sagittal, and look that it has hypodensity. So what it could be, maybe emphysema or sinus thrombosis, subdural hematoma. Hematoma, it could be hyperdense, except if it's chronic, but I agree that it can be. But before you rush in any diagnosis, don't forget to look in this. This is the clue for this case, that you will think about that this patient have sinusitis. When he have sinusitis and he spread the infection, so it will remember you in our case from while, especially if you have this, so something outside, and make, especially if this patient have something in the skin and go inside. So superior sagittal sinus thrombosis is complication with collection here and sinusitis here. So subdural emphysema caused by frontal sinusitis and sinus thrombosis or brain abscess. Don't forget this spotty tumor when it have something subcutaneous. So, and it can make osteomyelitis for the bone, as we saw it in the case. Okay. In the diffusion restriction here will help you to differentiate it from the sterile effusion. This is lovely picture that you like it. I think most of us saw it before. If you saw it one time, I think it will be easier for you to recognize it later. Plexiform neurofibroma, neurofibromatosis type 1, exactly. They like it. Can come to you in short question as a spotting or antimony case. This is the diagnostic criteria of neurofibromatosis type 1. That's why it's important to ask this patient if they have any skin manifestation, and if there is have anything in the axilla, in the groin, plus the radiological manifestation. Okay. Or bilateral optic nerve involvement. We mentioned this case before. Don't satisfy. Look for the other cuts. Do not miss. Look this optic glioma, other gliomas, because if the patient have bilateral glioma, he may have other gliomas. Okay, optic glioma, and there is some some hamartomas in the brain. Yes, sphenoid wing hypoplasia with plexiform neurofibroma. Look in the sphenoid wing here, and look in the orbit here, their orbit. Yes, so they like it in the MCQ, the causes of dural ectasia with anterior sacral meningeocele. Someone mentioned in the chat that there may be tuberous sclerosis. We mentioned that tuberous sclerosis have another type. Tuberous sclerosis in the brain have something called subependymal SIGA, subependymal giant cell astrocytoma. So it's different from ours, yes, and have also nodules, subependymal nodules. Okay, so what is the differential in this case? Dural ectasia with posterior vertebral body scalloping. It comes in MCQ in the FRCR. Yes, sure, it comes. Again and again, congenital anomalies. Yeah, I think it's this one, after what we saw in the Radiopedia, I think it's now a bit easier to recognize. Look in the sagittal image, it's more easier for you. Yes. when you see in the, if you have يعني, as a good approach, if you have a skull like this and this young patient, I will recommend you to look into two places as a first. Look here for Chiari and look here for corpus callosum. After that, look in your checklist, but start with this. Start here. If you find here corpus callosum agenesis, you don't find the corpus callosum, then check for other manifestation. And here for Chiari, if you find this tonsillar go down below the foramen magnum level, then you are talking about Chiari, and look which type of Chiari, Chiari 1 or Chiari 2 and so on. So يعني, as a good approach, try to start with this and go further with your checklist. They like it, this one, yeah. In the congenital anomalies, can anyone recognize as I go more quickly and more faster? We have just 3 minutes. Yeah, we are talking about holobronchocephaly, which is semilobar type. The allobar type is monoventricle. The semilobar type, there is partial separation, and the lobar type is like complete ventricular separation. They like this diagram. When you want good approach, in this case, look in the falcus. If you find the falcus, then it is, if you find the falcus, this is hydrocephalus or hydranencephaly. If you don't find the falcus, so it is holobronchocephaly. So this is very good approach. Look, search for the falcus. If you don't find the falcus, so it is holobronchocephaly. If you find the falcus, but the ventricles are dilated, so this is hydrocephalus. If you don't find cortical mantle, or you don't find cortex, you don't find like most of the brain are ugly, so this is hydranencephaly. So this is, for example, this is, did you find the falcus? Yes or no? Yes or no? I think people are sleeping now. I think it's time for sleep. Okay. Okay, allobar, yes. Allobar type with monoventricle, yes. One of the things that we like in MCQ are about to finish خلاص 1 minute, and we will finish the session, and I think it will be the end of this neuro. We will maybe next time we'll start musculoskeletal. They like this cranial type of cranionostosis, and they like that the scaphocephaly is sagittal suture. At least if you cannot memorize anything, memorize that the scapho with S, this is the sagittal suture. When it is like it happened that closure of the sagittal suture, it cannot be open, then it give you this lemon-like skull. Okay, I think the time is going away. I think this one is dehiscent jugular bulb. This one, yes. And this one is central pontine myelinosis. We mentioned it before in the last session. This one is fibromuscular dysplasia. Remember that in the that it can have this string of beads, yes, and it can have differential atherosclerosis with vascular spam. Thank you for everyone. I hope that this can be yeah, helpful. Yeah, this one is very good. Maybe we can take few cases